Hello, I'm Shelley Fold-Nasso, CEO of the National Coalition for Cancer Survivorship, and I want to welcome you to our webinar today. Thank you very much for taking time out of your busy schedule to join us. This webinar is part of our Survivorship Champions program, which is our program to engage and support clinicians and researchers who are interested in improving survivorship care. And we see it as a way to share best practices. We know that survivorship care is very dependent on the individual setting of whether it's in a community practice, an academic medical center, a community cancer center. And we're really thrilled today to have Dr. Crystal Labbato from the Baptist Health in Louisville, Kentucky, to share how she has managed the survivorship care in her institution. And her talk is entitled Beyond the Checkbox, Delivering Meaningful Survivorship Care in a Community Setting. We are so grateful to you, Crystal, for joining us today. And I'm going to turn it over to you to share your slides. We will record this. We will share the slides after the fact. And we will send out the recording and slides afterward. We know that's a common question we get. Please feel free to use the Q&A box to ask any questions, and we'll save the questions till the end of Dr. Labbato's presentation. Thank you so much for joining us.
Thanks so much for having me, Shelley. And I just want to thank you and Veronica and the whole team at NCCS for the opportunity to speak today as part of the Survivorship Champions program. And I want to thank all of you for being here. I appreciate your interest. And I'm really hoping to generate some ideas and share a little bit about what I'm doing here in Louisville for survivorship care. So let's go ahead and start. So I have no conflicts of interest to disclose, but I do want to offer a disclaimer, especially for folks who are taking notes out there about meeting the standards that are set forth by the COC and NAPBC for survivorship care. What I say, I am a clinician in a community setting, so please continue to work closely with your contacts in those settings as you are preparing your documentation for your accreditation reviews. So here's what I have planned for us to talk about today. We're gonna review some existing paradigms really quick of survivorship care, kind of talk about where we are now. We'll look at the COC and NAPBC standards and how they've evolved over time, and look a little bit at considerations that programs can consider when they're developing their survivorship programs. I'll talk a lot about the development and delivery of survivorship care here in the model that we are currently using. And then hopefully we'll have some time to talk about research and practice gaps and where we should be going next with all this. So this is just a little bit about my training. I wasn't always a nurse. I come from a fine arts background, but I feel like I bring a lot of those same kind of skills with me into my nursing practice. So I like to look at things as a big picture. I like looking at things as systems. My training is as a adult gerontology clinical nurse specialist, and so really I have been trained ad infinitum on the beauty of systems and how they work together, but it's complicated. I've always sort of worked in oncology on the periphery, so I did work at the bedside in a medical surgical center in a medical surgical setting, as well as helped start a phase 1 clinical trials program at the University of Cincinnati. And I've also practiced in inpatient and home hospice settings. So coming to a survivorship program, as I did here about 5 years ago, I really brought all of that with me. So when we're thinking about who a survivor is, certainly the NCCS definition of a survivor is somebody from the time of their diagnosis. And it's a word full of a lot of assumptions. Survivor is a loaded word. Patients don't always, that doesn't resonate with everybody. And so patients may not like that word, and they may not all share the same understanding of the word. And if patients don't, we know that we as clinicians have a hard time also getting our heads and our hands around what this concept is. So here's a slide from the NCI, and it's a very academic statement. And it really describes the multi-dimensional aspects of survivorship care. Cancer survivorship occurs on a continuum, and it's a multi-dimensional. Oh, people are not seeing the slides. Thank you. So here we go. Sorry, thank you for that. So, so survivorship care is happening on a continuum, and we're thinking about the family or the care community as the unit of care. Cancer is not just happening to one person. And the number of survivors continues to grow. So this is from the American Cancer Society. And we're projecting about 22.2 million survivors by the year 2030. That's about a 30% increase from 2019. And this is wonderful news because the treatments we're offering are working, because we're supporting people through their treatment, because the technologies are getting better. I like to describe survivorship and, as living well with, through, and beyond cancer. And that's really the sort of tagline that I promote here, because it's not a destination. And so this is a photo from a survivorship celebration in 2019, pre-COVID, as part of a collaboration with Kentucky Cancer Program. They're our state cancer program. And we asked participants, what would they tell themselves if they could go back in time? And so I really like some of these answers. One day at a time, ask a lot of questions. We were told, or I was told when I started survivorship, it was happening in distinct phases. And there was a lot of work done around the seasons of survivorship. And so this is sort of a parallel. And so considering my background in hospice and palliative care, that's sort of the mindset I brought to this. And so like survivorship care being conceptualized initially as linear and in distinct phases, we can certainly recall this is how we have framed palliative care delivery over the years. And so this is from the Canadian Hospice and Palliative Care Organization. They, I think, developed this model a little over 30 years ago, but it's not linear. So I'm going to share some images that I first saw in a 2014 letter to the editor of the Journal of Pain and Symptom Management. And this was written by Dr. Pippa Howley. She is the medical director at BC Cancer in Vancouver, Canada, and chair of their pain and symptom management and palliative program. And so she described something very different in that letter, and it stuck with me. So what we have is an integrated model of palliative care with disease management in the left side in the blue triangle, and palliative care kind of overlapping perfectly over the center on the right. And as you move down, you see the key kind of components of disease management. So what we think of as active treatment, chemotherapy, radiotherapy, but also there are all the sort of supportive things that kind of go in the middle of that that are contributing to the disease management, but are also palliative and supportive. But these two paradigms, they intersect on day one. So on day one of diagnosis, no matter what's going on, this whole centerpiece of things has to be addressed in order for the patient to have the best outcomes. Dr. Howley generously shared her slide deck with me to lend a little more context to my talk today. And she sent her blessings because she's so passionate about reframing how we think about the work we're doing in cancer settings or palliative settings. So survivorship is not linear, it's not a destination. And people arrive to their treatment at various points. So in this slide, you see that the person is, starting at the very beginning of their serious illness, and we're moving through the center, the meat of the care, right? And people tend to follow two paths. We're either going to rehabilitate them, or we're going to help them have a safe and soft landing in a hospice setting. Maybe people arrive to us though later in the disease trajectory. And so, you know, in where I'm working now, I'm seeing a lot of patients kind of toward the end of treatment. And so I'm kind of seeing them in this spot here where they're kind of finishing up that active treatment, moving towards rehabilitation, coping with late and long-term side effects, and understanding what comes next. Maybe we don't always know which way things are going to go, but we need to have maybe a plan for the worst, hope for the best sort of approach to things, so that people are really truly informed about what all of their options are for managing whatever it is that's on their plate as a result of a cancer diagnosis. So it's messy. I like to show this slides a lot in talks about survivorship to patients because it's not linear. It looks a lot more like this. So let's pivot. Let's look at these standards. Okay, so this is a quick comparison of where we started with the standards with COC and NAPBC. So in 2016, the COC, they were recommending a phase in for programs. So the first year, reaching 10% of all eligible patients with survivorship care plans, ultimately phasing in to reach 75% of patients by 2019. NAPBC, they got the ball rolling a little earlier. And so in 2015, they started with no minimum, but eventually they were hoping folks would be able to ramp up and provide survivorship care plans to 100% of patients. And programs struggled with this. You know, it can be time consuming. Preparing a survivorship care plan, time to complete that in the literature has been documented anywhere between 30 and 90 minutes. So there's a resource sort of component to that. Also, how does this work into workflows? So, you know, we had it right. We know that survivors have unmet needs. We know incomplete follow-up and surveillance is an issue. We know distress is an issue, but the document alone is not going to be the answer to this. And so we have some updates. This is the 2018 update from NAPBC. And so they changed they changed what they were asking from programs. And so instead of 100%, although they still want that to be a sort of a goal that we strive for, they've asked for, you know, 50% or greater of eligible patients to receive a survivorship care plan. But look who we're leaving out. We're leaving out patients with metastatic disease. And so what happens to these patients? This is the COC's update from 2020. And the COC, I feel like, is kind of edging closer to where we need to be. And so they sort of took away that bean counter 75% and said, you know what, survivorship care plans are important. We want you to keep and continue to provide those services as much as you're able. But also, maybe you should develop some other programs or connections to services for patients. And so they're looking for programs to develop at least 3 services, document the delivery of those services, and commit to improving them over time. Okay, so how do programs pull this off? Let's just start with, you know, a treatment summary visit. And survivorship treatment summaries, you know, we have all the information we need to be able to do this well. NCCN outlines it for us, ASCO does, ACS. And so what we're really doing with a survivorship care plan is providing a written document to the patient who is, that explains 3 things really: what happened, what happens next, and who does what. So really it's a roadmap to whatever the future may hold for that person. This is an example of a treatment summary from ASCO, and this is freely available to use without permission online from their website. And they also have other templates which are available, which can be disease specific. So you can tailor the summary to the types of testing and procedures that person would have had for their particular diagnosis. but also there are many others. And so many EMRs have begun to incorporate these in their programs. We use our EMR here, the function through Epic, to build our survivorship care plans. But again, I just want to point out that this can be really time consuming. And so maybe it is about, just giving somebody the highlights of their treatment. Maybe it doesn't have to be a very long drawn out process. Simple, I think, can be okay for a survivorship care plan. And there was there was an article in the journal, I think, of palliative care, it's talking about advanced directives and like why aren't we getting the outcomes that we hoped from a living will or advanced directive? And ultimately, I think we're relying on a piece of paper to deliver the outcomes that we're hoping for. And it's so much more than a piece of paper. It's always about the conversation with a living will, and it is about the conversation with a survivorship care plan. All right, so who should we be offering survivorship services to? So I've talked about, step one, defining, what sort of survivorship care plan you're going to use. Step two, who are the people that need to get a survivorship care plan? Is it people who finished all their treatment and crossed that finish line? Is it people with metastatic and advanced disease? What happens to them? Dr. Malika presented 2 weeks ago as a part of the Survivorship Champion series about caring for patients with metastatic and advanced cancer and what their survivorship needs are. A big question I get a lot is, if I've only had surgery, or if this patient has only had surgery, do they really need to see you? Well, surgery is a treatment, and I feel it is important. And we cannot anticipate the needs of cancer survivors based on their diagnosis, the duration or intensity of treatment, or any of our other sort of preconceived notions of what their needs might be. So really, it's for everyone. We don't need to wait to find out if somebody is going to survive their cancer. They're in front of us right now, and we must serve them. So well-timed and individualized survivorship care is appropriate for every person who's experiencing cancer. So step three is sort of connecting people to services. So here at Baptist, what we have developed is a sort of survivorship umbrella under which several other services are situated. And I work adjacent as well to our behavioral oncology team, who offers a lot of our psychiatric support services, behavioral health support services, and connections. And so that is an incredible collaboration and really helps me get people connected sooner to those types of resources. But, I was left with, some low-hanging fruit. And when I arrived, the lowest hanging fruit here in 2016 was tobacco treatment services. I think almost any program can benefit from enhancing their tobacco treatment services. This is a really easy grab. Brief tobacco treatment interventions and trainings are widely available. It doesn't take much. An intervention for tobacco treatment can take about 4 minutes. Quit lines are safe, effective, and underutilized. And so getting people connected to quit lines if there is no designated champion in your service. But I did obtain certification as a tobacco treatment specialist, so I am able to see patients individually who are interested in intensive counseling support and medication prescriptions. This was a bigger lift for us, older adult oncology. So in 2019, we did a pilot project we launched a pilot of an older adult functional assessment. And in the literature, you'll see this as a comprehensive geriatric assessment, a CGA. Geriatric is not a word that is tested here well. it's gone less well than the word survivorship has gone. And so older adult is where we are sort of is what we're calling this. But really, again, we're looking at a multidisciplinary, pull in the people that are needed when they're needed approach to older adults at the time of diagnosis. So getting them evaluated and identifying their needs prior to starting treatment, to minimize interruptions in treatment, to uncover maybe geriatric concerns and syndromes that might not be readily apparent to the oncologist in the office, to do a really thorough top to bottom, what are all the dimensions of your life and of your care, are we covering all those bases? And so in the slides that I think we'll share, I have many more details about these three sort of core services that we're offering here. And we can talk some more about them, but I really didn't want to get too much into those details because at the end of the day, there's not a cookie cutter formula for this. And so your resources that are available to you, your institutional support, all those things are going to play a role in what you are able to thread together. But let's look at a couple of cases because I really think this is where the rubber meets the road and you can really see the overlap of the services and how they're being delivered. So it's very much a collaborative and consultative approach. And so this was a gentleman, he was 72 years old, diagnosed with an adenocarcinoma of the prostate. He completed his definitive radiation in July of 2020. And he declined a survivorship visit when we first offered it to him. But he hung on to our information. And then in April of last year, he called requesting an appointment. And so when he came in, this is what was going on with him. He was having painful urination. He was passing out almost every time he urinated, reporting pain going down his back, down his legs, and into the soles of his feet. He was having some dribbling of urine, again, syncopal episodes as a result of this pain he was experiencing with urination, lots of falls, incontinent of bowel, poor appetite with a 30-pound weight loss since completion of treatment. And he was, of course his mood was disturbed because his whole life had completely changed. He was a very active gentleman who enjoyed spending time with his grandkids and traveling with his wife and hunting. And so, on exam in the office, the first time I met him, we did some orthostatic blood pressures. He had orthostatic hypotension. That was apparent. He had a near syncopal episode on the scale as we were getting him on there for his initial weight. He's very weak. Everyone receives an NCCN distress thermometer when they come in, and his distress score was 9 out of 10. I also screen everybody for depression with PHQ-9 and anxiety with a G87. And he had a significant score on his PHQ-9. So we talked through what his goals were and what his expectations were. Because he was really hoping that this was going to be taken care of and he was going to be able to resume his life. So we talked through that and really he decided, if I can just be stronger and have some more energy and get back to playing golf and playing with my grandkids, that would be great. Also, can you help me pee without passing out in a lot of pain? So he had a lot of physicians on board, which is not uncommon for older adults. So we talked through what his next steps could be, and I helped facilitate a little bit of that coordination. So he revisited urology. He was given an indwelling Foley catheter, and once that was placed, the passing out stopped. In addition, when I saw him for a follow-up, he was very happy to report that, but was still feeling a little dizzy And we looked at his med list, and he still had Flomax on his med list. So that was able to be eliminated. And he really started making some improvements after that. He was referred to oncology nutrition here. That's embedded in our center here. He was able to gain 17 pounds over the course of our follow-up. He was able to achieve regular bowel movements. He got to meet with oncology social work. We talked about his medication management. So he did have some underlying depression. And when I met him, he was on a dose of Zoloft of 50 milligrams. And so we talked about increasing the dose. Maybe that dose was subtherapeutic. And so when he met with his primary care and the dose was increased, his mood also improved as a result of that. You know, a lot of safety education, a lot of rehabilitation, PT and OT were involved. And the last time I saw him, he was thrilled. He was so happy because he was up in a deer stand that weekend hunting. It was amazing. So all of these services were able to overlap. I was able to see him after his treatment. I was able to apply you know, the skills and the tools of assessing and caring for older adults in a cancer setting. And we were able to have some good outcomes. This is another interesting case. So this was a 28-year-old young lady who was status post brachytherapy and cisplatin for cervical cancer. And so that was treated in 2018, and I met her 3 years later. And this is what she comes in with. You know, she's coping with early menopause. She's having debilitating hot flashes. Her mood has changed. She's reporting she just can't stop crying. She's having some incontinence of bowel. She was a young single mom, and she's working in a sort of truck transportation sort of environment. So outside all day, works with a lot of fellas. And the distress of having all these things happening to her body, of having the urgency of having to go to the bathroom, that was just another layer of her, you know, distress. I also did an ESAS with her, so an Edmondson symptom assessment. And, you know, her main issues were she was tired, nauseous, anxious, not eating, and just not feeling well. And when she came in, she's alert and oriented and anxious appearing. She had some abdominal distension, rating her distress an 8, again, a significant PHQ-9 score of 14, also significant anxiety. And so the plan that we worked on together was a referral to pelvic floor therapy. So this is a patient who had cervical cancer who had never heard about pelvic floor therapy. And so we got her connected there to help work on strengthening those pelvic floor muscles and help her regain some control of her bowel and bladder. She was also referred to oncology nutrition. Our dietitian here is indispensable. And again, as far as like the multidisciplinary approach that you see in palliative care, it's got to be there for survivorship care as well. And the dietitian we have here is an expert clinician. We were able to refer her to Friend for Life, which is an organization that provides matched peer support to any cancer survivor across the country. If you want to find them, that's friend4life.org, not friend the word for, it's friend the number 4. But that's a free service that we can get her connected to. And so we were able to get her matched with another young person who had been through the same treatment that she had been through and experienced the same sort of side effects. She was also reconnected to mental health provider. You know, it's not like it wasn't ever done. We talked about, you know, had she ever seen a community mental health provider, and she did, and it wasn't a good match, but that wasn't really followed up with, and she just kind of let it go. So we got her reconnected. You know, it's not always a good match the first time, and let's get you some support and as you progress. And then advanced care planning. Everybody I talk to gets to hear about living wills and advanced care planning. And I really think it's important to normalize those conversations early. That's not an original thought at all. But it's hard to, and I think people are sometimes reluctant to bring those sorts of things up in a survivorship setting, because what is my hidden agenda if I'm bringing this up? Do I know something that the patient doesn't know? It can make people really nervous. So normalizing that as a part of good medical care is something that I try to do. Okay, so, it's a team sport. It is a multidisciplinary endeavor. It takes every single person. And so when you are, getting the lay of the land, and you're looking around at your institution and your community, these are the kind of things you want to look for. Look at what exists at your hospital or within your system. The pelvic floor therapist is not here at my location, but they are at another location that is within driving distance for a lot of our patients. And so I'm able to refer them to that location. It's speech therapy. So that's a new connection that we're working on making here to get better connections with speech therapists who work with patients who are having mild cognitive impairment as a result of their treatment. Also, community partners, who is out there and ready to work with you to bring services and information to patients. I attended a Cancer Moonshot Roundtable, I guess this was back in 2019 as well, at our chapter of Gilda's Club, Cancer Support Community. And the biggest thing that came up in those conversations was, wow, there's all this great stuff out here and nobody knows how to get to it. And we have a lot of best kept secrets. And so how can we get the word out and connect the services? So survivorship, I think, is also important to approach it as if you're weaving together the threads. And I'm stealing this from a colleague of mine, Laura Mitchell, because there's all these threads out there. And so if somebody is able to put together these pieces, we can really have a blanket of support that holds patients. And then talk to patients. What do they need? Patient panels, I think, are a great way to gather information and resources. And this institution did use community member panels as they were developing the survivorship program way back when. And then also, what did the treatment team members wish they had? When I started, that was a big misunderstanding about what I was even going to do with the oncologist patients. Was I going to tell them that they had graduated? What was this nurse going to do with these patients? And so really helping the providers understand what you're doing, what you intend to do, and then hopefully matching up what you're doing to the needs that they're seeing in the office, to the things that they're hearing in those follow-up appointments. So this is back to Dr. Howley's slides. And so again, I can't stop thinking about these parallels and the importance of a multidisciplinary approach. And so, in Dr. Howley's mind, we're doing this early in the course of illness. So if we can conceptualize survivorship as very early palliative care for a serious illness, cancer is a serious illness. That can make a bigger impact. So getting involved earlier, not waiting to the very end. Services dipping in and out when the need arises. So maybe the patient that I don't see for an older adult assessment at the beginning of treatment doesn't want to come in for an evaluation, but maybe I catch them at the end of treatment for a treatment summary visit, and we can accomplish some things that way. I also want to just thank Dr. Howley and shout out a book that she co-authored with Gabby Irvu. And this is a book for patients and families living with a serious illness. And this is designed to be used from the time of diagnosis. Stop sharing. I'm seeing some questions popping up, and I think we can.
Thank you so much. Yeah, there's a bunch of questions. I can, you don't have to worry about, you can go look at them, of course, but I will try to go through them for you. I have a bunch of my own too. Thank you very much. That was wonderful. I love the bow tie model. That's really great. And I do think there's so much overlap between palliative care and survivorship care, and sometimes maybe we shouldn't even be worrying about these distinctions and just call it supportive care regardless of where you are in the cancer journey. And I think sometimes we get really tripped up by the wording and the distinctions. And I remember a talk by Dr. Patty Gans years ago when ASCO had their palliative care symposium, and her talk was entitled "Survivorship Care is Palliative Care."
Mm.
And it's really, it's true. It's just addressing all the needs of patients beyond just the cancer treatment specifically. Thank you for those case presentations. They were great. Two very different circumstances, but you really showed both the range of issues survivors face and how much you can help them by, really addressing these quality of life issues that really get them back to doing what is most important to them to be able to do. And so I thank you for that. That was really great. So one question that I think is a really good one. There's a lot of questions. I'm going to try to get to them, and then I also have mine. But what does your normalizing advanced care planning conversation look like? And could you give an example of how you bring this up with your patients?
Sure. So the way I'll usually start that is at the end of the visit, after we've had some time to talk and they get to know me, because it's usually the first time they're meeting me is in that survivorship visit. So what I will do is ask them, do you have an advanced directive living will? And if the answer is no, or even if the answer is yes, do you know, has anybody even told you what that is? So the first thing to do is just define what this thing is and take some of the mystery out of it, because people are walking around with all sorts of ideas about what a living will or not do for them.
Mm-hmm.
So first defining what it is, and then also letting people know that a living will is something that's important for every healthy adult 18 and over. And for many of the people that I'm seeing at the end of treatment, they certainly are healthy adults. They've experienced cancer, but they are going on to lead healthy lives. So normalizing it in that way. And also clarifying any misconceptions. What fears do you have about this sort of document? What experiences have you had with others that have had a serious illness and been hospitalized? So those are some ways, walking people through their own experiences. It really helps illustrate the value of early discussions, I think. And
Mm-hmm.
that is where it really comes together.
Great, thank you. So someone asked the question that she is working on developing a program at a medical center, and asked, what are the 3 core services that you mentioned? If you could repeat that.
The first service is the survivorship treatment summary. And then the other 2 services that I have as part of my practice are tobacco treatment. So I also see our patients individually for tobacco treatment, and older adult functional assessment. So back to that geriatric functional assessment for older adults at the beginning of treatment. So those are the sort of things, the practices that I oversee.
Okay, great.
But I just want to add, Shelley, I don't think you need to be doing it all.
Right.
Really, you need a conductor. You need somebody to organize and pull these together.
Well, that leads me to another question that we received in advance, because we let people ask questions before the webinar. And this was someone who's wanted your advice on how to start to bring some of these aspects of survivorship care to a rural setting that's not affiliated with a larger cancer center and really doesn't have the resources. So how can you start with limited to no resources? And she specifically asked about, how can you start with some of the telehealth services if you don't really have the technology? How can you do that with little to no resources?
Sure, that's a really good question, and an important question, because I think a lot of people are in the boat. And so, first, take a look at what you have, what's around you. Do you have any sort of rehabilitation access? Do you have access to information. So what information already exists out there that you can pull from and use to share with patients and use as a part of your teaching? You know, American Cancer Society, they have a PDF for every occasion. That's really an easy grab. I think also, you know, going back to treatment summaries, they're important. They are important. And the idea of a treatment summary is it helps the patient understand what's next. It helps their primary care understand what's next. And so preparing something written that summarizes the patient's treatment and then talking to them about it, I think if you can do just that, that's a big deal. And that can happen on the telephone. So perhaps the treatment summary is prepared and mailed out to the patient, and then you can follow up by phone. I do deliver treatment summaries that way to patients who prefer not to come in or have a full appointment. I do offer that. And I customize the information that I send to them. So for a patient who has had breast cancer with sentinel node biopsy, they all get information from American Cancer about lymphedema prevention and management. You know, these are the things to look for. Everybody gets information about eating after breast cancer. You know, what physical activity things are available. I think with COVID, we have experienced an explosion in Zoom, which has been, it's helped people get access. And so here we have a large rural community and many patients who travel an hour or two to come into Louisville for treatment. And so maybe going to Gilda's Club is not going to work for them. They don't want to come to Louisville for that, but Gilda's is still doing a lot of telehealth. So what else is out there? There are a lot of larger organizations offering telehealth type things. So those might be some places to start.
Great, thank you. I loved how you described the survivorship care plan as what happened, what happens next, and who's in charge. I think that's such a great way of simplifying what it is. And also, and the fact that you talked about it as a process, not just the piece of paper, I think is really important for people to understand, but that it doesn't have to be, so the treatment summary can be simple. It doesn't have to be. I think sometimes that is a hang up with electronic health records, and it could just be the highlights of it, right? To give that information both to the patient and then to other physicians with whom they might share the survivorship care plan.
Absolutely, absolutely. You know, just use it to walk your way through a conversation with somebody.
Yeah. So you mentioned physical rehabilitation, and how do you address that with patients, help make sure they know that that's an option for them, and lower any barriers to survivors who want to receive it? Because I think that often they don't necessarily know that this is something that's available to them.
Yeah, yeah. So how do I identify those needs, and then how do I get them connected? Shelley, is that what?
Yeah.
So at every visit, at every treatment summary visit, a patient is given the NCCN distress thermometer. And that to me has been the best place for me to start. So I asked them to fill out the distress thermometer, and they're able to, and that's freely available on the internet, and made available to everybody to use, copyright free, because it is so important. And so patients are able to identify what physical, emotional, spiritual issues are at top of mind. So I'm able to address those right off the bat. But then also sort of target my assessment questions around what symptoms would I expect or worry about based on what modalities of treatment that they've had.
Great, thank you. I have a few questions about how you deliver your care. So I'm going to start with this one and then move on to a couple of others that I'm going to combine. So are you able to share your EPIC-based treatment summary survivorship care plan templates? This questioner says that they've been building theirs in EPIC using the ASCO templates, but the treatment summary and survivorship care plan still take a lot of time to make user-friendly.
They really do. I don't know who was in charge of building that survivorship care plan template. my suspicion is it was an add-on package that the hospital had to buy from Epic. And so that magic is, I'm not really sure how that happens. But what I can do is share maybe a template for the note that I write at the end. And if that's helpful, because how do you even write a note for this kind of visit? That was a question that I had when I started. How do you document this and bill for it? And I see questions about billing, and all the billing I do is time-based billing. So, I'm doing a history and physical. I am connected to our medical oncology group. So the patients are billed through the medical oncology group. Well, my train of thought derailed there.
Well, that was, okay, so we had a couple questions about whether you were at your own clinic or within a clinic, and also how you get the word out about your clinic to patients.
Yeah.
And where the referrals come from.
Those are great questions. So the way I'm situated here, I think we're about a 250 bed hospital here in Louisville. And so the main hospital is across the street, and then our freestanding cancer center is just across from the main hospital. And so I work within a cancer resource center, and we do have a multidisciplinary clinic available. So I'm kind of underneath that umbrella. So I see our patients in the multidisciplinary clinic. And where I am, we're fortunate because the patient can walk right across the hallway and there's the radiation center. And they can go to the 5th floor and their medical oncologists are up there. And when they come in for scans, that's in this building. So we do have a lot of services housed right here. And I am employed by Baptist Hospital, but also like partly contracted out through the medical group so we can bill for ambulatory services.
Okay, and then are you able to bill your time for the survivorship care plan visit and the smoking cessation?
Yes, absolutely. Okay. Because the smoking cessation billing are, those are add-on codes.
Okay.
To a regular visit, so yes.
Okay, great.
Also, let me note that if you do any work around advanced care planning, those are billable services as well in 30-minute increments. And so if you're spending a lot of time talking about goals of care, and I didn't really talk a lot about survivorship needs for patients with advanced or metastatic disease, but they have a lot of goals of care issues. And is their prognostic understanding solid? And do they know what comes next? And what line are they not willing to cross for more time? Or what trade-offs are they willing and not willing to make? So that's advanced care planning services. And again, that's add-on charges for billing in addition to the main visit.
And how do patients with metastatic cancer get referred to you for that? And then also, what about if someone decides not to continue with further treatment? What kind of services do you give to them, or would that be through like palliative care or hospice?
Yeah. So let me start with referrals, because that was a real challenge when I started, because workflows are so complicated. So what we had to do, we tried to get the word out and, let's just tell all the doctors when the patient's done, put the referral in. Well, it is so hard to get people to change their workflow and change their practice. And so it takes a lot of education and re-education, and you just can't ever stop educating and getting the word out and talking about it. That's number one. I also show up to all of our treatment planning conferences, so tumor boards, and being a presence in those discussions and adding what I can just kind of helps everybody remember that I'm here. We did initially, because we had a hard time getting referrals, what we did is we collaborated with radiation oncology, and we said, okay, our population is going to be early stage breast cancers. And so on the last day of radiation for them is a perfect time for referral. And so all those patients completing breast radiation were referred to me. And so it kind of grew from there. Right now, this year, we've just started collaborating with the infusion nurses in the infusion center and having them drop their survivorship referrals on the last day of chemotherapy. I'm also collaborating with the advanced practice nurses in the medical oncology practice. And so when they're doing the chemo teaching and pre-treatment assessment, they do an incredible assessment. And so what they're doing now is screening older adults, 70 and older, for potential frailty. And then they're all offered referral for an older adult assessment before their treatment to maybe get them connected earlier. So those are a few of the referral pathways. Now, getting patients with advanced disease, that's also been challenging because, again, I'm trying to overcome some sort of misperceptions about what sort of work I'm able to do for patients. And so initially, patients with metastatic cancer would arrive to me by accident. And it really made the clinic staff a little nervous because I wanted to see them. Well, you know, the patient has metastatic disease. Yes, I do. And I can't think of anybody who needs a treatment summary more than somebody who's undergoing chronic or long-term treatment. So, and I can't imagine anybody coping with late or long-term effects of treatment more than somebody who's doing it for the long haul. And so, you know, I just kind of went ahead and saw them. And as I began to develop the older adult assessment and that piece, it became a little bit more evident. And so now my challenge is blending or presenting all these services as sort of a holistic package of services. Because still, I think I receive referrals from some doctors for smoking cessation, and I receive some doctors' patients for older adult assessments, and some will always refer their patients at the end of treatment for a treatment summary visit. And so how do I get everybody to understand the whole range of services that are available is our challenge that we're working on now.
It sounds like it's a lot of selling on your part of all the things you can do to help people. Okay, another question is, how would you recommend embedding survivorship care into a nurse navigation program?
Ooh, yeah, I think there is a lot of opportunity there. And I think that, you know, nurse navigators are doing survivorship care at the very beginning. So if we are keeping in mind that a survivor is a survivor from the point of diagnosis, then the nurse navigator is there essentially, you know, they're coordinating the care and providing information and setting up appointments, but they're also walking the patient through what to expect. And they may be the first one to identify a patient has some psychosocial needs or, you know, home needs that hadn't been addressed yet. So I can see that navigator role, you know, including a follow-up visit. And so if a navigator is following up with a patient sort of toward the end of things or in the middle of things, maybe they can prepare a quick summary for the patient and deliver it at that time and talk to the patient about it. This is what's happened so far. What questions do you have? What things are you worried about? You know, those are always questions that we should be asking along the way.
Great, thank you. And who is responsible for creating the treatment summary or survivorship care plan? Is that you or yes? Okay.
Right now, yes.
All right. So if you were to choose the top 5 to 6 services for a survivorship program, which would you say are the most important? And this particular questioner is asking about for a large academic medical center. So if you could do, you know, the top 5 or 6, what would you do?
So, you know, I think I would go back to, you know, the basic recommendations that NCCN lays out for all cancer survivors. And they are, if you smoke, stop or don't start. So tobacco treatment. There was an article in JAMA last year about tobacco treatment as the 4th pillar of cancer treatment. Like that should just be the standard of care. Everybody should be offered that as part of their care. So that's some low-hanging fruit. Alcohol use. So any education or information around, long-term use of alcohol and the risks and associations of alcohol with developing cancer or second cancer. Physical activity. So people need access to places to exercise, and they need to know how to do it safely, and they need to know how to resume exercise in a body that has been deconditioned by treatment, and do it safely without injuring themselves. That's something I see a lot, is people wanting to get back, especially if they were really faithful exercisers prior to their diagnosis. They want to get back and just start doing what they always did, and their brain doesn't match their body and they get injured, and then they have to wait to recover from that before they can resume, and it can just be really frustrating. So helping people with the tools to exercise safely and regularly. So does that mean that you're collaborating with a community partner like the YMCA and the Livestrong program, or places like Gilda's Club, or cancer support community that offer wellness type things like yoga and Tai Chi? Or is it mean that you're working with your physical therapists who you might be able to send a patient to just get started for their very first time with their own home exercise program? So definitely physical activity. Nutrition is another big. So access to a dietitian and good information about eating for cancer risk reduction, for cardiovascular risk reduction, because cardiovascular disease is a big concern for survivors. Those would be, and achieving and maintaining a healthy weight. So those 5 things, tobacco, alcohol, exercise, diet, and then surveillance, and making sure people understand what surveillance is available, and what screenings are available, and how to go about accessing those types of things, like a colonoscopy or low-dose chest CTs for lung cancer screening.
Great, thank you. So there's another question about, you mentioned that there are so many community resources that are just hidden gems that no one knows about. And so this questioner says works for a nonprofit cancer resource center, and getting the word out about their services is really hard. She says that doctors don't seem to have the time to talk about resources, and wonders if social workers can play a bigger role. And do you see social workers being assigned to every patient rather than leaving it as an optional service?
Oh my gosh, I would love that if everybody could have a social worker. Why are cancer programs hiring 2 or 3 social workers to take care of like hundreds and thousands of patients? It makes no sense to me. They're definitely underutilized, because social workers are connections to community resources, to transportation, to grants, to copay assistance. Our clinical social workers are LCSW, so they offer supportive counseling in-house. How cool would it be if we had more of them, and we didn't have to refer out a single patient for behavioral health services and supportive counseling? So yes, I mean, really, and look beyond doctors and nurses. Is it physical therapists, social workers, chaplains, dietitians, your cancer registrar? So if you do work with a cancer registry, my cancer registry has been invaluable, and they really helped get this program off the ground. So look for the helpers.
Yeah. Thank you so much. There's a few other questions we didn't get to. One person asked if we could share your contact information because she's trying to start a program and would love to get in touch with you. So if that's okay, we can do that. I want to thank everybody for joining us and for all your great questions. I'm sorry we didn't get to everything, but I think we covered so much ground, and I really appreciate your sharing your expertise and what you've been able to accomplish there, Dr. Labbato. So thank you very much. I just want to also make a note that we have applications or nominations open for the Ellen Stovall Award, which the nominations closed this week, and we would love for people to nominate cancer care providers or advocates who've really led in innovating in patient-centered cancer care. Thank you so much, Dr. Labbato. Thank you to Veronica and all of the NCCS team who helped us put this together. Thank you to everyone for joining us today. We really appreciate it, and we will share the slides and the recording. And we can also share Dr. Labbato's sample of her notes that she uses, that we can include that when we send out the recording. Thank you again, everybody, and have a wonderful day.